Our next presenters is chosen for Best People and Practice Environment. And here to talk about evaluation of MICU professional quality of life and experiences providing end-of-life care from MICU, let's welcome Nicole Hasna and Julia Yu.
Good afternoon. I'm Nicole Hasna. I'm chair of the Unit-Based Practice Council for the Tower 5 Medical ICU.
And I'm Julia Yu, and I am the co-chair for the EVPC.
Today we wanted to present the project that we performed last year, evaluation of MICU professional quality of life and experiences providing end-of-life care. And this is an overview of our presentation. This is a project we completed to fulfill our best people and best practice environment. So in the medical ICU, it was originally on Tower 6. In June 2017, we moved from a 12-bed ICU to a 16-bed ICU. And in doing so, we needed to hire over 25 new nurses to fulfill the ratios for these new beds. Between 2017 and 2019, we hired over 35 new nurses. Of these new nurses, most of them being new grads, or nurses that had no prior ICU experience. In doing so, with this high influx of nurses, a lot of the feedback that came back from these nurses that they were not prepared for the morbidity, the mortality, and the end-of-life care that they provided in the ICU. So being an MICU nurse in this and being on the Unit-Based Practice Council, I brought this feedback to the council. And a lot of the overwhelming fear and concern from the nurses came from a lack of resources and a lack of support that they felt being new ICU nurses with this morbidity and mortality. Our patient population has a lot of chronic diseases, and we are meeting people at the end of life and providing comfort care. And so bringing this back, we wanted to accurately gather information that would allow us to assess the staff quality of life and how this contributed to burnout, compassion satisfaction, and compassion fatigue and moral distress in the unit, and how this would negatively impact a unit as far as morale and just professional quality of life. Secondly, we wanted to gather feedback of possible resources that staff would need in providing end-of-life care in the medical ICU. Lastly, we wanted to determine staff interest and staff buy-in for a peer support group or a support U group at UC Davis. So some definitions that I wanted to cover before we get into the results of our project is that there's the overall concept of professional quality of life. And with this, it's split into two categories. There's compassion satisfaction, which are the positive aspects of professional quality of life, positive feelings, positive feedback. It provides a positive environment, a positive work environment, and positive emotional responses to your work. Counter to that is compassion fatigue. And compassion fatigue is split into two categories. These provide the negative feelings associated and that provide a negative professional quality of life. The first being burnout. These are the emotional descriptors of compassion fatigue, and these are chronic. They develop over time to develop burnout and have negative feelings such as hopelessness and a lack of desire to complete work. The second component being secondary trauma. This can be acute, but can develop and progress over time. These are traumatic experiences from the nurse themselves in scenarios, or trauma from patient to nurse. And these exhibit physical symptoms that staff provide that provide a negative professional quality of life, including things such as sleep difficulties, intrusive images, and avoiding different reminders of personal trauma within the work setting. So for the method of our project, in 2019, in June, we sent out an online survey via Google to the unit. We had 72 nurses at the time, and we sent this out via email. And in doing so, we gave the nurses a month to respond to the email. We used two validated measurement tools for this. The first being the effort, ward, and balance ratio, or the ERI, and then the professional quality of life, or ProQOL measure. And if you're familiar with any research that's being done as far as professional quality of life and burnout and secondary trauma in nursing, these are very strongly used and validated tools within this research right now. The content of the survey included demographic information as far as nurse experience, night shift versus day shift, years in nursing as a medical surgical nurse, a tele-nurse, an ICU nurse, as well as clinical experiences dealing with different diagnoses that we had in the unit. Additionally, we wanted information regarding nurses' experience in providing end-of-life care. Following this, at the completion of the 30 days of the survey being available, we completed a data analysis, which included both descriptive and multivariate statistics.
Okay, so onto the results. About 80% of our staff responded as a total of 57 participants. And it was pretty good participation between day and night shift nurses, about 50-50. And of course, like Nicole mentioned, demographics. It was really interesting because in terms of years of experience, as well as experience prior to coming to the medical ICU, there was no statistical significance to our survey outcomes. However, for day and night shift nurses, we did see some significant differences when it came to our data collected, and we'll go more into that later on. So as a big kind of overarching big points of our results, we found that all respondents scored either in the moderate or high category for compassion satisfaction. That means it's a good thing. That means most of our nurses felt like they found pleasure in the work that they did. No respondents scored in the highest category of burnout or secondary traumatic stress, which is also a really good thing. That means none of our nurses were in the highest risk category for burnout or secondary traumatic stress. However, there was a significant amount of nurses that reported experiencing conflict, moral distress, or lacking resources when providing end-of-life care. To be specific, 30 to 40% of the nurses in the medical ICU. So we decided to investigate a little bit further by considering the possible factors that contributed to burnout, moral distress, and compassion fatigue, which we were using to gauge the overall professional quality of life. So when we considered compassion satisfaction, we mainly focused on the awards or recognitions received by our nurses. So from our survey, we found that 8 nurses had received a DAISY Award on our unit. Approximately half of the respondents received a thank you letter in the past year. The even more interesting thing was that there was a higher proportion of day shift nurses who had received a thank you letter in the last year compared to night shift nurses. So why is this important? Well, those who received a DAISY Award and those who received a thank you card in the past year tend to have a higher compassion satisfaction score. That means those had a higher pleasure in the work that they did. When we wanted to look into burnout and secondary traumatic stress, we sort of focused more on the concept and the experiences of providing end-of-life care. And it was really interesting to see that 68% reported experiencing moral distress, 60% reported feeling of lacking resources, and 54% reported experiencing conflict with other staff. Interesting thing is, those who received DAISY Awards had lower burnout scores. And those who expressed wanting more resources, those who experienced conflict, had higher burnout scores. Those who had a DAISY Award had lower secondary traumatic stress scores. And those who wanted more resources, those who had more conflict, had higher secondary traumatic stress scores. And also, what's really, really cool is that those who were interested in participating in a peer support program also had a higher secondary traumatic stress score. So it seems like they knew what they needed, which is really cool. It really geared what we were about to do with our project here. Another interesting point was that the overall night shift nurses did have an overall higher secondary traumatic stress score than the day shift nurses as well. So seeing these associations and the data that we collected, we really wondered how we could provide interventions to really gear our practice to promote higher compassion satisfaction while lowering burnout and secondary traumatic stress. In other words, how can we increase possible protective factors and reduce possible risk factors?
With this, we wanted to analyze some of the limitations of our study. First of all, we only surveyed the MICU unit, and more specifically, the MICU nurses. This did not include doctors, RTs, EVS, or HUSCs. Additionally, due to turnover in the ICU, the medical ICU, the numbers did not allow for a follow-up study after implementing some of our interventions that we found from this study to be able to follow up with those nurses. But something to highlight, in the American Journal of Critical Care in March of this year, there was a study by Monroe, Morse, and Price entitled "The Relationship Between Critical Care Work Environment and Professional Quality of Life." And this study was performed at a single hospital with 4 ICUs using the ProQOL measurement tool. And they found similar statistics and findings within their study in regard to compassion satisfaction, burnout, and secondary traumatic stress. So these numbers parallel with this larger institution study. I think it gives some validity to our numbers that we found just within our medical ICU at 80%. Some of the strengths that we found with our study was that we had a really high response rate. We had 80.2% of our nurses respond, and so we felt that this was able to be statistically significant to the findings that we found. We performed a robust statistical analysis that was able to provide conclusions that were concrete in numbers. Additionally, with these findings, we were able to take them and apply interventions within our unit-based practice council and the MICU as a whole to help intervene and hopefully provide a better professional quality of life for our nurses.
So once again, just to go over some of the conclusions, overall DAISY Award recipients had a higher compassion satisfaction score and lower burnout score. And as well as higher burnout scores would tend to be associated with those who felt like they didn't have enough resources when it came to providing end-of-life care. So what exactly did we do with that? It was really, actually, you're going to go over peer support, sorry.
That's okay. So with this, we started a peer support group with a lot of guidance from Michelle Lindenberg, who founded the Support U at UC Davis. We have currently established a functioning, completely isolated subcommittee of our unit-based practice council. And this subcommittee is functioning. It has meetings. We've had lots of projects. And it's comprised of both day and night shift with a strong presence of night shift in hopes to reach those nurses that had higher burnout scores. Additionally, a lot of the feedback that we've had is a complete shift in our work environment and the morale at the unit. There's been so much positive feedback with our peer support group, and it's made some great changes within our unit, especially during the current situation with the pandemic. Ways to improve is that we are emphasizing in our unit-based practice council to utilize BEST awards through the UC Davis system, and just positive feedback and positive support through peer review.
And then for the compassionate extubation order set, a group of doctors as well as nurses collaborate together to help create a standard order set when providing end-of-life care. This really helped eliminate some of that gray area, some of that conflict, some of that confusion when providing end-of-life care that a lot of our nurses had expressed having. It also has a new RDOS assessment tool, which some of us are using now, to better assess for discomfort when experiencing end-of-life care. When the patient's experiencing end-of-life. We also have a comfort care cart available in the unit, and it has some goodies, some resources, speakers, and things like that that the family as well as the staff can utilize when providing comfort care.
We would like to strongly thank Serena Fazio, Stephanie Lockhead, David Duncombe, and the Unit-Based Practice Council, as well as Felicidad Loomis. They helped with a lot of the statistical gathering and analysis, as well as Sandy Taylor and Susan Stewart, and then the support of Amy DeRoy. Any questions? Sorry, it's not going to the next slide.
Oh, there you go.
There you go.
Questions?
Was there a difference between, I guess, experienced nurses and nurses with less experience in terms of the compassion fatigue that they were suffering?
Statistically, no.
Surprisingly not.
Sometimes there is a question brought up about statistical analysis related to whether it's correlation or causation in terms of, does a DAISY award mean that someone will have less burnout? So I wonder if you guys thought about that or discussed that in your group.
Yeah, I can speak a little bit to that. Serena was the one that did a lot of the statistical analysis for us. So if you have a more detailed question, you're welcome to email it to us and we can forward it to her to address that. But I think for us, a lot of this project was more about just sort of getting some big overarching themes. I think we were just trying to get a feel for like what exactly, might be a cause, or, hey, do you think if nurses get more awards, do you think that'll might, make them a little bit more satisfied with their workplace? It sort of is also in response to the effort reward imbalance ratio that we had used to do the survey. So it's sort of the idea of like how much effort you put into your work and whether there is a sense of reward gathered from there. So in terms of reward, there's always the emotional reward of just caring for someone who needed you. But there's also a sort of physical award. And so a way we sort of highlight that was sort of whether the nurse had received an award in the past working here.
Great, thank you. There appears to be a question up here asking about, is the compassionate order set available to all providers?
I would assume so. It's an order set available,
like compassionate extubation. That's supposed to take place. Sorry. It's a compassionate extubation order set within EMR. It's in addition to the comfort care order set that is available to physicians.
Great. Any other questions?
Can you give us an example of what that includes, what that means, the order?
The compassionate extubation order set. It includes a ventilator titration. So out of simply having a patient off of their current ventilator settings and palliatively extubating them, it allows the RT to use the RDOS scale that has symptoms of discomfort and breathing patterns and signs and symptoms of respiratory distress integrated to it. And based on those score, the RT and the bedside nurse are able to work collaboratively to use PRN medications to bring that score down and to titrate the ventilator so that there are no signs of respiratory distress before extubating the patient.
Got it. Thank you.
I just want to comment. I love the connection between gratitude and reward and recognition, and just the fact that 8 DAISY awards there too. It's something that I think we should share with the Barnes family from the DAISY Foundation. Just that connection, I think, would thrill them. But I love how you connected the dots there. Nice job.
There's also a comment from Amy DeRoy, the manager of the MICU. She noted that the compassion extubation order set is only for MICU at this time while you're gathering data. So thanks, Amy, for that comment.
Comfort care order sets are available.
Comfort care order set is more universally available. All right, thanks. Any other questions? Great work, you guys. Thank you.
Thank you.